So there was a recent study published in the New England Journal of Medicine that finally has done a placebo-controlled trial on administering vitamin C to people with sepsis. For many years, we've gone back and forth in the medical community on whether vitamin C might be helpful. There are a lot of reasons for that. I want to review some of the history and the progression of thought in this area in light of the most recent study that shows that those who received IV vitamin C actually had a higher risk of death or persistent organ dysfunction compared to those who received placebo. So vitamin C actually made things worse when we finally got around to doing a decently sized randomized controlled trial. With that in mind, let's go back and look at older articles. So this article is from just talking about recent insights at that time into the role of vitamin C in sepsis. This is an important statement next. In vitro evidence. Anytime you see in vitro evidence, you should automatically be suspicious because a lot of things happen in a test tube that do not happen in actual human beings. If it says in vitro, if it says in the lab, if it says in a mouse, in a rabbit, in anything other than actual humans, you should be very skeptical. Even if it's human tissue in a lab, a lot of things work in a test tube that do not work in actual human beings. Bleach kills COVID-19 in a test tube, but in humans it causes poisoning. So just because something works in a lab environment or in vitro does not mean it's actually going to be important. But in vitro evidence supports a critical role for vitamin C in cellular mechanisms relevant to the pathophysiology of sepsis. So this is exactly the kind of thinking you see Andrew Huberman engaging in, Rhonda Patrick. Many people online engage in this kind of flawed thinking, which is extrapolating from the physiology, the pathophysiology, and trying to then make claims about what will happen in an actual human being. The flaw in thinking is thinking that we understand the physiology so perfectly that we will be able to predict what the outcome will be when we actually do it in a human being. This goes into what sepsis is, what happens. Here's a section on the pathophysiology of sepsis. Significant changes in glycocalyx structure, vascular integrity, and vasotonus result in capillary leakage. That leads to decreases in blood pressure. Interestingly, microvascular thrombosis certainly was a big part of COVID-19, but also was something that was trying to be addressed by the medication Xigris. And that was actually taken off the market. I'm going to do a whole video just on Xigris and the story of Xigris. But because sepsis does cause microvascular thrombosis, it was thought that a medication that directly addressed that would improve outcomes in sepsis. And in fact, very similar to what we're finding with vitamin C here, it actually made things worse, and patients did worse on that medication, which was then removed from the market. Several mediator substances, TNF-alpha, oxidized lipoproteins, thrombin, overwhelming production of reactive nitrogen species and reactive oxygen species. So these are the pro-oxidants. This is oxidation. This is inflammation. And the idea of vitamin C is to provide antioxidant activity to address that. These reactive oxygen species damage cellular membranes and cellular junctions, leading to vasodilation, and ultimately the DIC and other forms of dysfunction and sepsis. In critically ill patients, vitamin C is markedly decreased. So this is an important thing. We're starting to build this story, right? That human beings are dependent on exogenous vitamin C because we can't make our own. We need it in healthy organisms, and in critically ill patients, vitamin C is decreased. So it makes a lot of sense that supplementing vitamin C would help, and we know that it's an antioxidant. So it makes a lot of sense that this would help. And I want you to understand why it makes so much sense in the context of knowing that it actually causes harm when we test it. So the rationale is to supplement vitamin C in sepsis and shock. Two of the medications we give for sepsis, norepinephrine and vasopressin, those are two medications we use to keep the blood pressure up. And vitamin C increases endogenous, that means your own body's production of norepinephrine and vasopressin. So once again, giving vitamin C helps your body produce the same substances that we are using to keep your blood pressure up. We know that vitamin C is depleted in critically ill patients, and we know that we need it for health, and we can't make it on our own. Parenteral administration of vitamin C may improve microvascular function in septic patients. So here's a citation. We can go look up that citation. Mechanism, this is 2009, mechanism of action of vitamin C in sepsis. Modulates redox signaling in the endothelium. So circulating levels of vitamin C are low in patients with sepsis. Parenteral means by IV per the most part. Giving IV vitamin C raises plasma and tissue concentrations and may decrease morbidity. In animal models, once again, here we are, in animal models of sepsis, IV ascorbate is vitamin C. IV ascorbate injection increases survival and protects several microvascular functions. So these observations are consistent with the hypothesis that microvascular function in sepsis may be improved by parenteral administration of vitamin C as an adjuvant therapy. So again, back in 2009, we found that it altered redox-sensitive pathways, the septic induction of NADPH oxidase, again, and inducible nitric oxide synthase, which lowers blood pressure and contributes to some of the dysfunction of sepsis. And we found that vitamin C actually improved these markers. And this is, once again, a thing I will harp on, is markers are not diseases. Markers are not diseases. Markers are markers. And until you do a test of survival in humans, not in animals, we will not know the answer. And so I want you to look at how this edifice is constructed around vitamin C, only to fail when we actually put it to the test. So its contribution to endothelial cell proliferation, apoptosis, vasodilation, etc., render vitamin C an important agent in the treatment of pathophysiological changes in septic shock. Moreover, vitamin C has bacteriostatic activity. So vitamin C even stops bacteria from growing. It prevents them from growing. How could this fail to be effective? Well, because test tubes are not human beings, and what happens in a test tube cannot be extrapolated to what will happen in a human being. You see people all over the internet doing this. Notably, PhDs do this because they spend their lives examining these detailed pathways, and then they try to pretend you can immediately extrapolate it because they think that once you understand the pathway, it must always function that way, and that denies the complexity of the human body. I'm going to make a video as well on complexity theory, chaos theory, as it's popularly called, and why those extrapolations fail. So it is known, again, from in vitro studies. It binds to the alpha-adrenergic receptor, one of the main things for blood pressure, and enhances activation by epinephrine. Summarized the beneficial role for vitamin C, growth, survival, ability to maintain vascular responsiveness, showed that vitamin C may prevent inflammatory increases. Some evidence that steroids increase vitamin C uptake. We'll get to that in a second as well. Here's the important bit. For critically ill patients, neither do we know an optimal vitamin C plasma concentration, nor is it known whether supernormal plasma concentrations are more beneficial. In other words, we don't know in actual humans. Currently, there are no large randomized control trials. Now, obviously, this is in the context of now, finally in 2022, a controlled trial was done. Here, in a double-blinded randomized trial, okay, that's promising, 28 adult surgical patients. Whoops. Okay, here's a cohort. Now, that's interesting. 595 critically ill surgical patients, pretty decent size, examined the effect of vitamin E and C in preventing pulmonary morbidity, organ failure, found a reduced incidence of organ failure, shortened ICU length of stay after early supplementation. This is an important series of statements. A cohort study is not a prospective double-blind randomized controlled trial. A cohort study cannot show treatment efficacy. That's number one. Number two, they did not examine the effect on survival. Pulmonary morbidity, that's long-term lung effects, organ failure, and they found reduced organ failure and shortened ICU length of stay. This is exactly what the remdesivir people did, right? Remdesivir, they originally tried to show that remdesivir reduced mortality, and then midway through that trial, with no explanation, they switched to just show that remdesivir shortened the hospital length of stay for COVID-19. So instead of showing mortality benefit, they moved the goalpost and say, well, it was a shorter ICU length of stay. The patient spent less time in the ICU. Now, maybe they spent less time in the ICU because they died, but they didn't measure that. Note the absence of any commentary on mortality or survival. That's important. Again, double-blind randomized control trial, 28 patients, pretty small, but okay. Decreased vasopressor requirement, faster weaning of vasopressors. And 28-day mortality was lower in the ascorbic acid. So that's excellent. So this trial is actually well designed. It's just small. It's only got 28 people. So there was this early evidence. That's actually good quality, or it's at least a proper study. In human patients, in actual sepsis, it's just small. It's only 28 people. And so, again, we're setting up the idea that this could work. This is similar to some of the early studies on hydroxychloroquine or ivermectin. It's when you do small trials, things seem to look okay at first sometimes. It reminds me a bit of the Jupiter trial as well, showing the effect of statins in people with high CRP, written, of course, by the owner of the patent on high-sensitivity CRP. That conflict of interest is ignored, generally speaking, but they also stopped the trial early. So this is why I argue so strongly against any trial that is stopped early. This was a critical study. Patients receiving vitamin C in combination with thiamine and hydrocortisone had significantly reduced mortality. Let's bring that up. I started giving the combination here. This was published in 2016. I think I read it probably in 2018 or 2019 that I came across this. And I started giving hydrocortisone, vitamin C, and thiamine to all my septic patients because this looked so good. It was a retrospective trial, not prospective. IV vitamin C, hydrocortisone, and thiamine basically showed effective in preventing organ dysfunction and reducing mortality. So again, they did mention mortality. That was one of the things that sold me on it. It was 8.5% in the treatment group compared to 40% in the control group. So number one, the fact that they reported the actual percentages allowed me to calculate the absolute risk reduction. And so 40 minus 8 is 32. So it's a 32% reduction in mortality. And that was fantastic. Now, it was not a prospective trial. It was a retrospective trial. It was in a total of 94 patients. So relatively small, but 94 is not bad, actually, especially if you're showing such a big reduction. My thought at the time was that if you're showing a 32% reduction in 94 patients, when we finally do a trial in 500 patients or 600 patients, surely we must be able to see some reduction, even if it's not as much. That's the common pattern we see in these kinds of trials is originally you see a huge effect, and then as more studies roll in, the effect is smaller and smaller than we thought. So then in 2020, someone actually did a prospective randomized controlled trial with 216 patients, treatment with the combination IV vitamin C, hydrocortisone, thiamine, compared with IV hydrocortisone alone. Interestingly, that's a topic for another day. Did not significantly improve the duration of time alive or free vasopressor administration over 7 days. So when we finally got around to doing a trial, it actually did not work. So I myself started giving the combination of vitamin C, hydrocortisone, and thiamine based on the results of that study. However, in 2020, it was disproven, and that's exactly what we're going to see again with vitamin C by itself. So the conclusion of this study in 2018 was that vitamin C deficiency is frequently observed in critically ill patients. After 1 century of in vitro experiments in animal models, there is an abundance of plausible data for the protective effects of vitamin C. The lack of randomized controlled trials and uncertainty regarding optimal dose, timing, and adverse effects impeded clinical acceptance, and preclude a recommendation for vitamin C. Further research is needed. So these authors were appropriately cautious. They were summarizing the literature to that point. So that brings us finally now to this study published in the New England Journal of Medicine in 2022, evaluating vitamin C. And what did they find? Again, a total of 800 patients underwent randomization, vitamin C versus placebo. So it's a prospective randomized controlled trial. 50 milligrams per kilo of body weight every 6 hours, up to 96 hours. Composite endpoint of death and persistent organ dysfunction on day 28. In the vitamin C group, one patient had low blood sugar and another one had acute allergy anaphylaxis. Can't say it was because of the vitamin C, could have been because of something else, but those were the adverse effects that were noted. But the important bit is that the individuals that got vitamin C, death had occurred in 35% of the vitamin C group and 31% of the placebo group. So this again is the difference between a retrospective trial and a prospective trial. The difference between 872 patients and 94 patients. The difference between a test tube and actual human beings. Difference between theory and thinking we understand the pathologic mechanisms compared with testing the theory in reality. This is one of my big arguments with people who try to say we understand this so well we can predict what things are going to happen. We just don't. And that's shown over and over again. Reminds me a bit of that quote, in theory there's no difference between theory and practice, but in practice there is. And that's what we see over and over again. So, interesting study. I think since 2020, I've stopped giving vitamin C with hydrocortisone and thiamine. Most of my colleagues as well in the hospital stopped that. But this, I think, is the final nail in the vitamin C and sepsis idea. Very good size, very good study. I'm sure somebody will come out and say, well, they just didn't give enough, 50 milligrams per kilo. The average adult male is 70 kilos, so that's 3,500 milligrams every 6 hours. So somebody's going to come in and say it should have been 5,000, should have been 10,000, should have been however much. But I think that is a very high dose of vitamin C every 6 hours. And I think we're seeing the fact that that actually increased death. The other thing I want to point at is we've developed this weird cultural idea that inflammation is always a bad thing and anything anti-inflammatory must be good. And that is a dangerous oversimplification. There are several conditions in which inflammation is sufficiently problematic that anti-inflammatory medications, treatments, and behaviors improve outcomes. Certainly for COPD, certainly we see that in acute COVID in the ICU with the improvement on dexamethasone. We see that chronically in things like rheumatoid arthritis. But recently, and I'm going to go through this in another video, studies on low back pain actually having a higher risk of transitioning to chronic back pain if the person took anti-inflammatories. We need to learn when to trust our body's inflammatory process. It's designed by evolution over a very long period of time. And if you're going to outsmart 4 billion years of evolution, you've got to wake up pretty early in the morning. It's not that it never happens. I think that we need to continue doing experiments, but we need to learn to only trust placebo-controlled randomized trials in humans. That's the gold standard. And that don't test markers, that don't test blood tests, but that test survival, mortality. So, placebo-controlled, randomized controlled trial testing mortality is the standard. And we need to learn to follow that standard very rigorously, because over and over again, what happens in a test tube, what happens in an animal model, does not predict what happens when we actually test it in humans. We need to learn this lesson.